Hi, it's Dr. Cassidy here to talk to you about respiratory concepts and acute respiratory failure, also known as ARF. I want to let you know off the bat that many of these slides are wordy and don't have images. I added images where I thought it would benefit learning, but didn't want to turn the presentation into hundreds of slides to make it look prettier. I did specify on some of the slides things you do or do not have to memorize, and I'll also let you know as we go through if something should be memorized or just understood. Okay, let's get into it. The first few slides are a review of some definitions, and it's expected that you do know the definition of all the terms in these next few slides. Oxygenation is getting oxygen to tissues and organs to sustain life. It includes ventilation and perfusion, which we'll talk about in a few slides. Oxygenation, or the ability to oxygenate cells, depends on how much you breathe in and how fast you breathe in. That's your respiratory rate. How many breaths you take in a minute. How much O2 you breathe in depends on certainly how deeply you breathe. That's the amount of oxygen in the air that you're breathing in. Up to now, you may have only referred to that as a percentage, where America needs 21% oxygen, and the rest is other gases. Another way to state the amount of oxygen is FiO2, fraction of inspired oxygen, which for room air would be 0.21, written as FiO2 0.21. Yes, I do understand that actual fraction would be 21 over 100, not a decimal point. But these are all the exact same numbers, 21%, 0.21, and 21 over 100. They're all the same. In medical terminology, it's called FAI2, so I think that's what we're going to go with. On this next slide is what we just talked about. You remember that nasal cannula oxygen measures in liters, provides a percentage of oxygen from 1 liter, which is approximately 24% O2, to a non-rebreather mask that provides 100% O2. So that patient is only getting oxygen and no other gases with every breath. Well, the FAI2 for that would be 1. I just wanted you to get used to using FAI2 because you'll need it for this module, and it'll come up again in vents, and you'll need it as a nurse if you're working in acute care. Okay, more definitions, which these are probably reviews, so I'll go through them quickly. Remember, you do need to know these definitions. Anaerobic metabolism is cells making energy from carbohydrates or lipids if the cell doesn't have carbohydrates available. The cell uses oxygen to make the energy, and the waste product is carbon dioxide. Now, when the cell doesn't have oxygen to make energy, it can do it without oxygen if it has to. That's anaerobic metabolism. The waste product of anaerobic metabolism is lactic acid, and that leads to metabolic acidosis. So it's not a sustainable way to make energy. In sepsis, remember the patient's lactic levels are elevated. That shows that their tissue doesn't have enough oxygen and has to resort to anaerobic metabolism. That's why sepsis is so serious, because the tissue and organs aren't getting oxygen, aren't getting enough oxygen. Okay, I got off track there. I did want to make that quick. Let's move on. Hypoxemia is low oxygen in the blood. Remember, emia is blood. Hypoxia is low oxygen in tissue, and hypercapnia is high carbon dioxide in the blood. It has the EA in the blood. Ventilation is the flow of air in and out of the alveoli. It's abbreviated with a capital V. I remember by thinking of opening my windows to ventilate my house, just like your alveoli have to be open to ventilate. Ventilation is controlled by tidal volume, abbreviated as capital V, lowercase t. That's how much air you breathe in, like how many liters of air you breathe in. When a patient has shallow breathing, they have decreased tidal volume, so decreased ventilation. The other thing that controls ventilation is the respiratory rate. If a patient has a low respiration rate, they have decreased ventilation. The other part of oxygenation is perfusion. And that is abbreviated with a capital Q, which stands for the quality of perfusion. And perfusion is the hemoglobin being delivered to the alveoli to pick up oxygen. Perfusion is affected by many factors, including how much hemoglobin there is, how much fluid there is, the blood pressure, the heart rate. Of course, when any of those are decreased, there is less or slower blood flow to the alveoli. Decreased perfusion means decreased oxygenation, just like decreased ventilation means decreased oxygenation. Okay, yes, for effective gas exchange to occur, we need ventilation and perfusion, both of them. This is an image of ventilation perfusion to show you what happens at the alveoli level of gas exchange. I know it's probably a review, but you have had a lot to learn between now and the last time you looked at this anatomy, so I thought it would be helpful to go over it. And it'll be easier to understand acute respiratory failure and ARDS if you have these concepts down. And this is how we measure oxygen, either with an arterial blood gas to obtain the partial pressure of oxygen, and the normal range is 75 or 80 to 100, and to obtain an SaO2, which is the percentage of hemoglobin that the oxygen is bound to it, and normal is 95% or higher. Non-invasively, we just use a pulse ox and get the SpO2, which also shows the percentage of hemoglobin that is oxygen bound to it, and the normal level is also 95% or higher. The partial pressure of carbon dioxide is also measured with an arterial blood gas, ABG. It's also included in the BMP lab draw, basic metabolic panel. And the HCO3, the bicarbonate, is a measurement of CO2 because it carries CO2. We're not getting into chemistry of how this occurs. You just need to understand that HCO3 is also a measurement of CO2. Another way to measure CO2 is with end-tidal CO2 capnography. The green box on the intubation tube is measuring the carbon dioxide with every exhaled breath. That's abbreviated as capital E, capital T, CO2. We don't get into understanding and reading an ETCO2, but you should just know basically what it is. Okay, let's get into acute respiratory failure, also known as ARF. ARF is not a disease itself. It's worsening respiratory function related to a disease or diagnosis that interferes with gas exchange. It can be a problem of perfusion, of ventilation, or of both. Now, the gas exchange problem can be inadequate oxygenation or too much retention of carbon dioxide, hypercapnia. This is an image from your book, and I included it because it breaks down nicely what ARF is, but I do not want you memorizing the exact numbers that make the patient meet criteria for being officially diagnosed with ARF. That's unimportant. What's important is understanding what acute respiratory failure is, knowing what interventions to use to prevent it, recognizing early signs and symptoms so that you can be treated early, and knowing what to do if your patient is in respiratory distress. Hypoxemia is considered oxygenation failure because there's a decrease in oxygen, and hypercapnia is considered ventilatory failure because there's inadequate ventilation of CO2 out of the body. Okay, I really like this image. A VQ mismatch is when there is less V ventilation or less Q perfusion than expected. So normally the same amount of air and blood reach the alveoli. There's equal parts so that there's always the right amount of oxygen reaching the alveoli to fill up the hemoglobin receptors and the right amount of hemoglobin reaching the alveoli to take up that oxygen. When there's a mismatch, the amounts are different, so one of them is left hanging. It doesn't matter which one, the result is the same, decreased gas exchange, meaning decreased life-sustaining oxygen getting to where it's needed, everywhere. The cloud-shaped blobs are the alveoli that carry air, and the blue and pink tubes below are the capillaries that carry blood. And the left side of the slide depicts problems with ventilation, and the right side depicts problems with perfusion. I'll go through each of them. The first one has no ventilation, but full perfusion. The alveoli are probably full of fluid or a mucus plug. They're completely blocked in this part of the lungs, so there's no gas exchange. This is called a shunt. The next one has some ventilation, but not full. There's still full perfusion, but again, without the full ventilation, there's decreased oxygenation. This could be pneumonia or just shallow breathing. In both of these, you can see there's a VQ mismatch. The Q is fine, but the V is decreased or absent. The diagram in the middle is normal. It's what's expected. No restriction of ventilation or perfusion. Now, the diagrams on the right show perfect ventilation, no problem there, but the first one has decreased perfusion, maybe from a really low blood pressure or narrowed artery. The outcome is the same, decreased oxygenation. And the last diagram shows, again, full ventilation, but there's no perfusion. It's completely blocked, maybe from a pulmonary embolism. So there's no gas exchange at these alveoli. This is known as dead space. Not a great name, but that's what it's called. And here again, there's a VQ mismatch. I hope this slide helps you understand VQ mismatch. In the next few slides, I'm going to discuss the different mechanisms of hypoxemia and hypercapnia. We'll start with hypoxemia. There are 4 mechanisms that cause hypoxemia. We just went over the first one, VQ mismatch. The next one is a shunt, which, yes, is a VQ mismatch when blood leaves the lungs without participating in gas exchange. But a shunt is also when blood leaves the heart without participating in gas exchange. That's like when a child is born with an anatomical defect and blood goes from the right ventricle to the left ventricle and skips the lungs. So that is also a shunt. The next one is diffuse limitation, which is when there is damage to the alveolar capillary membrane, like pulmonary fibrosis. A classic sign of diffuse limitation is hypoxemia that occurs with exercise, but not at rest. That's because when you exercise, the blood is moving more quickly past the capillary membrane, so it has less time for gas exchange. If there's damage to the membrane, low oxygen will occur more when the heart rate is faster. Alveolar hypoventilation is really just decreased ventilation that causes hypercapnia, but it leads to hypoxemia, so it's included there. The consequences of hypoxemia include hypoxia, makes sense, low oxygen in the blood leads to low oxygen in the tissue. And also remember the other consequences is acidosis because the cells are going to shift from aerobic metabolism to anaerobic metabolism, releasing lactic acid as they do. This slide lists some of the manifestations of hypoxemia, how the body responds to low oxygen levels. I'm not going to read them all, but please pause the video and go over them. You're expected to know all of these. Hypercapnic respiratory failure can be from overproduction of CO2 or decreased ventilation of CO2 out of the lungs. There are 4 mechanisms that can cause this. A central nervous problem like brain injury or drug overdose that suppresses the CNS. A neuromuscular condition that causes muscle weakness or paralysis, right? You need your muscles to work to breathe, like your diaphragm, which is a muscle. Again, if you're not taking a deep enough breath, you won't be ventilation, so you'll be retaining CO2. Diseases like multiple sclerosis and Guillain-Barré can cause this. Chest wall abnormality that restricts chest wall movement also decreases ventilation. So now your muscles are fine, but there's a problem with the chest wall restricting inhalation. The result is the same, decreased ventilation leading to hypercapnia. This can be from trauma, spinal deformities like kyphosis, and obesity. I've seen this in a lot of obese patients diagnosed with hypoventilation syndrome. That's what this is. So this is becoming more common. And the last one is very common, airway and alveoli problems where air is trapped. That's COPD and asthma. These are obstructive diseases. And the consequences of hypercapnia include acidosis, this time from CO2 retention, which causes acidosis in the blood. This slide lists some of the manifestations of hypercapnia, how the body responds to high carbon dioxide levels. Again, I'm not going to read through them, but please pause the video and go over them. You're expected to know all of these. I wouldn't worry too much about memorizing which symptoms are specific to hypoxemia versus hypercapnia, except morning headaches and somnolence really are specific to hypercapnia, and I want you to be able to recognize that. For the other ones, just understand that they all mean respiratory distress. This slide just shows the same symptoms of respiratory failure listed again. I do want you to know which are the first and early signs and symptoms because to practice nursing safely, you need to recognize changes in your patient early so that you can be treated early. The slide is just a visual depiction of some of the symptoms to make sure that you know what the medical terms mean. So pause the video and take a look at it if you need to do that. This slide is diagnostics that may be used for respiratory failure. You're probably familiar with all of them, except maybe the VQ scan. That's a 2-part imaging where they measure airflow and then measure perfusion. It's used to diagnose pulmonary embolisms. This slide contains common drug classes used to treat respiratory failure, and you should be aware of these medications by now. For instance, a common corticosteroid used in the hospital is Solumedrol. Common bronchodilators used are albuterol and Atrovent. I don't expect you to know which type of antibiotics are used, just the word antibiotic is enough. Okay, last section, the super important stuff, the nursing care. And you should know all of these on the rest of these slides. Don't worry, it's only 3 slides. Prevention. How do you prevent your patient from going into acute respiratory failure? Identify at-risk patients and initiate interventions. Incentive spirometer, 10 times every hour while awake, used properly. Cough and deep breathe exercise, early and frequent as possible ambulation. Optimize hydration and nutrition. And do frequent focused respiratory assessments. Notice changes early. Pay attention to restlessness. It should prompt you to check an SpO2 and count those respirations. Also, an elevated heart rate means the body is working to get oxygen. And trend these numbers. Maybe a heart rate of 80 isn't elevated, but if your patient has been 60 all morning and slowly creeping up, pay attention. Prevention is the best thing you can do as a nurse. Oxygen therapy. We want to provide the least amount of oxygen in a manner that the patient can tolerate to keep the SpO2 at 95% or higher. This means if your patient is at 100% on 2 liters nasal cannula consistently, you should turn it down to 1 liter and see how they do, and you may be able to wean them off. This also means if your patient is at 94% consistently, you should address that. I would want to know their respirations and work of breathing as well. Are they working hard to maintain that 94%, or are they not even aware it's low? Maybe just reposition, cough and deep breathe will bring it up. Maybe they just dip for a few minutes and now they're fine, or maybe they need oxygen. My point is, don't just leave a patient with a below normal SpO2. Investigate and do what you need to get that level back to normal. Yes, patients with COPD may be retaining CO2, and some providers may order permissively lower oxygen levels. I've seen orders like titrate O2 to maintain SpO2 between 88 and 92%. That's an easy order to understand and follow. The difference between that and being a nurse who decides to allow a patient's SpO2 to stay at 88% because they have a diagnosis of COPD is a world of difference. So please don't be tricked into being that nurse that withholds oxygen from a patient that might and probably does need it. That's the opposite of prevention. That's harm. Of course, I would talk to the provider if there was a person I thought given the oxygen to would harm them, or I've had patients tell me that they keep their sats lower at home because their doctor told them to. I just message the provider and ask them to write the order. Then I can follow the parameters of that order. We do a lot of things independently as nurses. We have our own practice. That's separate from providers' orders. But deciding to let a patient's SpO2 remain in the 80s or even low 90s is not one of the things we can do to a patient any more than we can let the patient sit with the respiration rate in the 30s. I apologize if I seem preachy. I just see this frequently, so I feel compelled to ensure that you all know that even though it's common, it's not standard nor safe practice. A normal SpO2 is 95% or above, and normal respiration rate is 12 to 18, maybe 20. And those are the parameters that we should expect to see and address if they're off. Okay, patient positioning. Head of bed up to improve ventilation. If a patient has pneumonia on one side, you can lay them with the good lung down so that the fluid drains out of the bad lung. If they have pneumonia in both lungs, do frequent repositioning side to side to mobilize secretions. And hospitalized patients with RS or COVID should be prone. This slide shows why proning works. I don't want you to memorize parts of this image. I just want you to understand that it works and to use it on appropriate patients. The image on the left is a patient lying supine. You can see the heart is pushing down in the lungs. Also, the liver isn't shown, but it is pushing down as well. And all the fluid is spread across the larger back portion of the lungs due to gravity. When you turn the patient over, the heart and liver aren't pressing on the lungs. The lungs are now on the top. Also, the front lungs, which are smaller, are filled with fluid from gravity, and the back lungs, well, all of that surface with more alveoli are free to ventilate. This is why proning works. I did this with all my patients with COVID when I was travel nursing, and I would watch their sats go up very quickly once they were lying on their stomachs. It was usually challenging getting them to agree to lay on their stomachs because it's scary, and it took a lot of trust, patience, and I gave them all back massage. And they would stay there for an hour or more, and it made a big difference. Okay, these are my references, mostly images. And this is my contact info for questions or to schedule office hours.